welcome to Medical University of South Carolina and to Charleston and to the conference for these 2 days on new findings in neurobiology and treatment of borderline personality disorder. It's a delight to have you all here, and we're looking forward to, I think, a series of really informative presentations. I'm going to start with just a couple of announcements, and I'll also introduce myself. I'm John Oldham, the chairman of the Department of Psychiatry here and executive director of the Institute of Psychiatry. And I'll be kicking off the program, making the first presentation, and then sort of moderating and leading the rest of the conference and introducing our speakers. We have a lot of information in your syllabus about. Will alert you in advance that I will not be making laborious, lengthy introductions of our speakers. We will only do the very minimal intro, and lots of good stuff is in the material. I'm getting a lot of static here. Turn this one off. All right, that's off. Can you still hear me okay? Yeah. Okay, very good. Let me start with a couple of announcements, just housekeeping. We are going to be videotaping this entire conference, and so we appreciate it as you come and go. If you would try not to slam the door in the back and keep chatting too much in the audience, I would like to acknowledge the hard work of the organizers of the conference, and some of them you'll be hearing from later from NEA.BPD, and I'll tell you a bit about that in a second. Harry Hoffman, Dixie Kennedy, Trish Woodward, and they're up here in front. And also in my office, Liz, Kathy, and Mark Barber with AD and Josh, and Kevin Dawkins, who made DVD we're going to be seeing tomorrow. So there's a whole team that's been working hard to put together a very good conference for you. There are disclosure statements of all the speakers in your materials, so if you're interested in that, you should have that as reference. We try to ask not to have food in the auditorium, but bottled water is fine. You need to bring that in. We will be having lunch today. It's a boxed lunch. It's going to be a beautiful day, so we'll set up tables out on the deck outside. The lunch is only provided today since the conference closes a little earlier on Sunday, and so people will have time to go down to Charleston, to the downtown area, and have a lovely southern lunch, and have lots of choices. If you are looking to get CME or CEU credit, please turn in your completed evaluation forms on Sunday, and you have to sign in and out each day to get credit for both days. And finally, just a word or two about the principal sponsor of this conference, which is one in a series sponsored by the National Education Alliance for Borderline Personality Disorder. This is one of a number of organizations, but really one of the leading ones that has grown into a really important contributor to help bring attention to the need for research and education in the whole field related to the severe problem of borderline personality disorder. And NEA.BPD has asked a number of us to participate on its board, which we've been happy to do, and has really been in business since 2001, so it's a relatively new organization that was put together really by a huddle with some family members, consumers, and professionals to come up with the idea, and it was sort of spawned at Rockefeller University in New York. The National Institute of Mental Health has been partially sponsoring with some grant funding the ongoing educational efforts of NEA.BPD, and that's been a wonderful benefit and partnership between NIMH and NEA.BPD. So as you look at the website, if you're interested, and we're actually building a new website component, which is going to be a forum, this ongoing educational forum, you'll see a lot of information on there. You'll also be able to take a look at the past conferences that the group has been sponsoring throughout the country. This is the first one held in Charleston, and we're delighted to join as a partner for this conference here in the university and the Department of Psychiatry. Again, the goal is really to bring state-of-the-art, state-of-the-science information forward so that we can really help our families and help our patients who are struggling with this disorder and help providers understand the latest research and the latest information. And that's what we're going to be focusing on today. And we chose the theme of new findings in neurology, neurobiology, and treatment, specifically for borderline PD. I'm just delighted that we have a roster of speakers that is outstanding. These are some of the leaders working in this area throughout the country, but not just here, also internationally. We have speakers joining us from Germany, from Canada, from London, as well as a wide range of representatives here in this country. Let me mention one other housekeeping announcement, and that is that one of our international speakers, Martin Bogus, is scheduled to speak this morning, but is not yet here. And we hope all will go well and that he will get here. He called and said that his airline was not being terribly comforting with a lot of exact information, but his best guess was that he would get here a little before noon today. So we hope that's correct. So what I'm going to do is ask him to be our first presenter right after lunch, and then flip that presentation with two presentations by Harry Hoffman and then by Dixie Ann and Hillary, which are scheduled now for right after lunch. So they will be presenting at 9:45 this morning. Then we'll have our break. We'll go on with the program with Dr. Swiloff and Dr. Kokaro, and then we'll hope that Dr. Bogus will be here for us to hear him right after lunch. So with those announcements, I think we'll go ahead. Just to remind the speakers, we are videotaping. I've been asked to encourage you to be statue-like, stand in one place and not travel too much. And I said I would announce that without a lot of confidence that it would actually be remembered, but nonetheless, we'll try our best. Okay, so with that, let's proceed, because I'm going to try to set the stage for the next 2 days. And what I am going to be talking about, I called it in the program the borderline realm, but it really focuses on the concept of borderline personality disorder and where it came from. So let's just do a little moment of history here. Borderline personality disorder, as many of you know, appeared as an official diagnostic term in our DSM language in 1980 with DSM-3. However, the concept is not a new one. Patients didn't get invented in 1980. Patients have been struggling with these kinds of disorders for some time. We think we're a whole lot farther down the progress road in understanding them than we used to be. But terms that were used historically include some of the ones you see on the screen. Euler's concept of latent schizophrenia. The use of the word borderline really is usually attributed to Stern in 1938, where he talked about the borderline group of neuroses. So right away you see something interesting, and that is that the concept of borderline is linked in some way historically to the word schizophrenia in some cases, to neurosis in other cases. And this was sort of being sorted out. More often, you would see it as one type of this borderline layer between the psychoses and the neuroses. Zilborg talked about ambulatory schizophrenia. Helena Deutsch had the concept of the as-if personality, which was in the realm of sort of hysteria, hysteroid kind of behavior, which was thought to be not so benign as symptom presentation might appear. Polk and Politan at my former home in New York at the New York State Psychiatric Institute many years ago, that was before I was there, by the way, talked about a concept called pseudoneurotic schizophrenia. And those of you who remember that paper, it talks about patients characterized by pan-neurosis, pan-anxiety, and pan-sexuality. And in fact, if you go back and read those cases, they're very reminiscent of what we now see in some patients with borderline conditions. And Robert Knight then talked about borderline states, Frosch's concept of psychotic character, and then ultimately the Brinker study looking at the borderline syndrome. So these are some precursors. Now that Brinker concept looks pretty familiar, doesn't it? So this is in '68. Here they talked about failure of self-identity, anaclitic, or meaning clinging, dependent relationships, depression based on loneliness, which really presages John Gunderson's concept of the problem of being alone, and the predominance of expressed anger. So we're already beginning to narrow and focus in on a concept that's very, very close to what we find in the DSM language. I apologize for this busy slide, but people sometimes think that personality disorders actually just got started in DSM-3. Certainly not true. They've been in actually every single edition of the DSM, which started in 1952. Originally, they were called personality pattern disturbances, trait disturbances, and then sociopathy was kind of separated out. Some terms that we use in the personality disorder general discussions and studies have been in every edition. So paranoid, for example, you see all the way across, and others as well. Some earlier diagnoses have disappeared. We used to have a concept called inadequate. That's no longer a diagnosis. Another was asthenic. It's no longer a diagnosis. And some have emerged for the first time. And others, by the way, have moved from axis 2 to axis 1, or what we would call that now. So, for example, explosive used to be a form of disorder. It's now on axis 1 as intermittent explosive disorder. So as we rethink and re-understand these disorders, we try to conceptualize them and categorize them in the basis of developing knowledge. Borderline appears for the first time in DSM-3, and that's something that really is what we're focusing on. So that just gives you a little historical perspective. This is the development of a construct depicted by John Gunderson in his wonderful book in 2001 on borderline personality disorder. And what he describes here is that some of the contributors to the construct of borderline, the issues that need to be looked at and have been studied to try to establish whether this is a valid construct or not, or a valid diagnostic illness, and then some of the people who contributed, some of whom I'm sure you're familiar with, and some who aren't listed there but are here in the room have been very much contributing. What we did, we meaning the field, was, as you know, develop a construct of personality disorders for DSM-3 and 4. The diagnoses on the list have changed a little bit, but most of them have been pretty stable. And we've clustered them so that there's a group called odd eccentric, another dramatic emotional, that's usually the way the DSM puts it. I've added the word impulsive, so I think that's part of the concept. And then another called anxious fearful. So in essence, what we've done is group the disorders around a dimension, or a set of dimensions, which are really cognitive on the top, affective and emotional in the middle, of the sort of depressive, impulsive flavor, and affective of the anxiety flavor on the bottom. Now, how prevalent are the personality disorders, and then we'll tune into borderline. If you think about schizophrenia, which has a prevalence of 1% in the population, this is a little unfair because this is the prevalence of the whole group of personality disorders, which is about 13%. But if you looked at the prevalence of the group of psychoses that would bundle them all together, I don't know what that would be, but it would certainly be a lot more than 1%. But if you look at individual disorders, you can see that there are a number of different things. Anybody, the residents in my program who are here can't talk because I've already talked to them about this and they know the answer, but does anybody else want to call out what surprises you on this slide? These are prevalence data, door-to-door, population-based epidemiological study.
Avoidance.
Avoidance, exactly. Isn't that odd? 5% of the population, door-to-door, this is not a clinical sample, have avoidant PD. Well, the catch is that this is done in Oslo, Norway. And actually, Sven Torgersen, who did this study, has written about this in the archives. That's where these data are from. And in the narrative text of that article, he suggests that this may be a reflection of the Nordic temperament. Now, that would not be entirely without controversy. There was a very interesting article in Science, actually, in 2005, looking at personality, actually using some of the Big Five, the five-factor model, and looking at it across cultures. And what was really interesting was that there is a belief stereotype that cultures have, which differs from the results of a direct interview of the population. And when you do that, the cultural stereotypes disappear. It's a very interesting whole subject of its own. But even if that's the reason in the explanation, it may explain some of these responses in this particular study. What Torgersen did, he wrote a chapter for the textbook that with Andy Skodel and Donna Bender, I had the good fortune to edit. Sorry, I'm jumping here. I've got to stay away from this machine. It has some TMS wave to make it move, I think. What Sven did was try to look at what the data were up there, and he put these other studies together and batched them to try to do an approximation of a pooled data analysis to see if there was a change in what the prevalence would look like, not just relying on the Norway study. And all of these are in the U.S. except one, which is Mayo's study, which is in Germany. And they're not great comparison studies because most of these are probably unfairly loaded, since these are family members of patients or groups that are going to already be permeated with a greater degree of risk factors. But still, it was an effort to see what would show. And here, you can see both the median and the means, and you go back to borderline, which, remember, in that previous, if you focus on that, is 0.7, and usually in the published literature it's referred to as 1 to 2%. So if you go to see it here, what you see is the mean is 1.16, so we're in that 1 to 2%. And if you look back at avoidance, it drops down, and actually the median is 1.35. So you are seeing differences from the specific data from the Norwegian study, which is an interesting thing to think about. And you know that the DSM has criteria, it has polythetic systems. So there are 9 criteria. There have to be 5 out of 9 criteria. And I put this on just to remind you that number 9 was not in the previous DSM-3 or 3R. This was added in DSM-4. Originally, the notion that borderline was on the spectrum of the schizophrenia psychosis conditions did not turn out to be the case, and borderline instead is on this emotional impulsive set of spectrums. This tilts it a little bit back toward that psychosis spectrum. Borderline itself is an extremely heterogeneous category. As defined, actually this number, I think, is 256. So with doing the math, with 5 out of 9 criteria, there are 256 official ways, like the DSM, you can be borderline. So we're not talking about one condition, we're talking about a family of conditions, all of which would meet the diagnostic threshold, but which can be very different from each other. It's also becoming clearer that our criteria set for borderline is a mix of unstable stress-induced symptoms and stable personality traits, or dimensional traits or characteristics. I'll come back to that in a few minutes. There's going to be a 2-day conference that a number of people who are on our speaker panel today will be participating in, and I'll be attending as well. That's going to be held in New York next week, which is looking at borderline PD from the point of view of a phenotypic, dimensional, conceptual approach. And that's going to be an attempt to think in the early stages as we're moving toward DSM-5 to try to reconceptualize our basis for defining this condition. And this issue will be prominent in that discussion because we think there will be some suggestions of revision along these lines. If you look at level of functioning, you'll see a broad range. Borderline is, in fact, all the way from severely dysfunctional to not as badly so. And that's seen also in other disorders. This would be antisocial, and this would be schizoid, schizotypal, generally pretty severely dysfunctional. And this is a busy slide, and the main point to point out here, this is from a paper by Seaver and Davis, and it attempts to sort of describe a Mark, help. Let's try again. Hey, Mark, I need you. I don't know what I did. Okay, I'm back in business, sorry. Just trying to make a pointer work. What I started to say is this is a chart that looked at what the spectrum links would be between axis 1 and axis 2, perhaps biological markers, characteristic traits, and even characteristic defenses and coping styles. And my main point here is that borderline is on 2 of these dimensions, impulsivity and aggression, and affective instability. So it's that heterogeneity again. There are different types of borderline that we see. And this is what Larry Seaver has stated, that if we did look at what would be the genetically based traits and the phenotypes that he would argue are the sort of principal, fundamental ones underlying borderline pathology, would be affective instability and impulsive aggression. And we'll get back to that in a bit. This is a slide from John Gunderson's earlier book that he repeated in the 2001 book, again looking at where borderline would fit in the context of other categories of pathology. And this inner circle is what we define as that big bunch of 256 flavors of borderline by the DSM definition. And this broad circle, or this oval, is Kernberg's concept of borderline personality organization. And the words are sometimes used without remembering or noticing that we're talking about very different things. The borderline organization is in fact a theoretical construct that is based on theories of intrapsychic structure. And that theory you could summarize here, that shows that if you define organization and intrapsychic structure with these 3 concepts of defenses, primitive defenses, identity diffusion, and loss of reality testing, that all of these are present in psychotic conditions. None is present in neurotic conditions. And primitive defenses and identity diffusion are, but reality testing is maintained. I sometimes put a little plus minus here because primitivity of defenses under stress certainly can lead to transient loss of reality testing, but it's sort of not lost in an ongoing, stable, permanent way. Now, what are we beginning to learn about borderline PD out there? And some of this you'll hear a lot more about in the later presentations, such as the one from Emile Picaro and others. But there are some brain imaging studies that are not specific to borderline that are showing some abnormalities, and we're seeing that mostly in the frontal lobe, And also in the limbic system, we're seeing some changes. And here we're looking both at functional studies, but there are also some structural studies with MRI. And these actually mostly are looking at the limbic area. And the sort of other studies that are done show also reduced volume. This is also not specifically just due to stress, because if you factor that out, it's still clearly a significant reduction in volume. And so the implications here are that we're seeing abnormalities in prefrontal, corticostriatal, and limbic networks that may relate to reduced serotonin transmission and behavioral disinhibition. I would always add in at least some patients with borderline personality disorder, because they're so different that some of them may be coming from different problems. What causes borderline PD? And I'm just pausing for a minute to remind you that I'm moving through rather rapidly from a kind of very distant perspective, trying to set the stage for what we'll be zooming in and drilling down on in more detail as we go forward into our other presentations. But there have been a number of different theories of etiology of borderline PD. Again, remind you that there is no one disorder, and therefore there may be no just one cause of the disorder. There could be a number of different things that could lead to the diagnosis of borderline. And among them include some of these that you see here. Don Klein, Hegel Fiskell, Mike Leibowitz, and others have talked about affective impulsive dysregulation. In other words, this could be just a subsyndromal or a special syndromal version of some kind of mood disorder. And I think that's probably accurate and relevant for some patients, but not all. Kernberg's notion would be that really we're dealing with a problem of excessive aggression. We don't often think of Kernberg in connection with genetic theories. However, this is really a genetic concept. This is an inherited temperament of inordinately intense and high levels of aggression. But also it could be secondary, as sustained trauma led to this kind of aggressive behavior. Workers such as Masterson and Lindsley have talked about maternal withdrawal, but that really should be parental withdrawal. And it's a notion that, in fact, the parents interfere with developing autonomy and independence, and they need to be needed. And the withdrawal is what happens if there is independent growth and maturation in the child, and therefore it's kind of a smothering, inhibiting, fixing, and develop effect of those types of situations. Mahler and Holbrook and others have talked about introjective failure, and there may also be conditions that look like borderline conditions, but really could be primary neurological conditions. Tony Angelonis and others have written about that. Another example that's not up there is adult ADHD. Sometimes Rex Cowdery has written about that in the past. May have some similarity in some cases. How heritable is BPD? Well, we have a twin study that's published by Sven Torgersen, who's a Norwegian researcher who did the epidemiology study. Optometrists have been looking at this a lot, and you're going to probably hear some really greater detail from John Livsley about this whole area, but there certainly are some persuasive evidence in studies that tell us that there is some genetic factor at play in at least some of these patients. It may be around this impulsive, novelty-seeking dimension of behavior, but there may be other inherited contributions to some of the patients with this disorder. What about early abuse? This is work by Thomas Rinne in the Netherlands, and he actually presented this at an international meeting in 2003. And the point I'm making here is that actually in his view, he views aggression and impulsivity and reduced serotonin as far more likely to be in borderline patients who are male. One other point that I would say as an aside, by the way, if you look back at the epidemiological data, you see some interesting things. One of which is we generally read in the textbooks that the male-female gender distribution of borderline personality disorder is heavily weighted toward female. Sometimes you'll see 80% as a figure that's quoted for the ratio for females to male. If you do the epidemiology door-to-door study, it washes out and it's about a 50-50 ratio, or it's not significantly different between males and females. And I think the reason for that, and this is my own speculation, is that patients with borderline personality disorder who are female are more often comorbid with other conditions like depression and are also more likely to come for treatment. Males who have borderline personality disorder are often comorbid with antisocial personality disorder. We see them in different arenas. They are in the correctional system and they're less likely to present to clinical services for treatment. So if we're looking at gender distribution, we're mostly looking at treatment populations, and that's going to be weighted toward females in a way that I think is not going to be mirrored in the population or in other studies. That just was reminded of that in this particular study here. The other point that Thomas and others make is it's not just a single episode of abuse, but it's got to be sustained abuse. And what that does is, in fact, lead to some significant problems with regard to the HPA system, the stress hormone system, and that can be actually a sort of resetting of that biology that persists long term. Here's a suggested theoretical way you might construct that, possibly some kind of faulty attachment. I'll come back to that in a minute in terms of attachment notions. In genetically vulnerable children, and this is the bidirectional gene-environment interaction, so potential abusive parents or caretakers could sense that vulnerability in these kids, seek them out, be specifically selected, and then there's sustained abuse leading to all of the cascade of pathology that follows. There have been some really interesting animal studies. This is studied by the Steve Sumi group, and it just looks at maternal absence. And if you deprive the early infants of mothers, what will lead to is an alteration in serotonin hormone. If you provide a substitute nursery support, it doesn't restore those serotonin levels, and their trait life can stabilize in infants. So you have reduced serotonin, produced by this early separation from the mother that seems to be sustained, even if you've gotten pretty good substitute mothering that you restore fairly quickly. This is what they said. Isn't this interesting? Evolution has selected for mothers to provide emotional security and to punish inappropriate social impulses, perhaps providing the input needed to properly link the serotonin system to the frontal cortex region, which is of crucial importance in both emotional regulation and impulse control. That's coming from an animal study. That's very interesting. We don't want to make the mistake of applying it as established fact in humans, but it's very compelling. One other study that's very compelling was a study by Jeremy Copeland, Len Rosenblum, and others at SUNY Downstate, or SUNY Brooklyn. And this was a foraging condition study, which I think is quite interesting. And they put mother monkeys with their infant offspring in 3 different environments. One was where food was plentiful all the time and there was no problem. The other was where food was scarce, hard to get, but if the mother worked for it hard, she could always succeed and get food for her offspring. The third was what this refers to here is called variable foraging design, and it meant that all bets were off. Tomorrow there was food all over the place. The next day it didn't matter what the mother did. There was absolutely no way to succeed. The next day it didn't matter what the mother did. There was no way she could get food for her offspring. The next day there it all was again. And this completely destabilized the environment. And the suggestion is, that these mothers couldn't master the environment. They became so distracted and stressful. They became either dismissive or neglectful of the offspring, and enormous problems occurred. And look at the histories of the early caretaking environment for many of our patients with boredom. Not for all, but for some. And we do see that kind of inconsistency. Have a mother where there's severe pathology, or let's say periods of substance abuse, alternating with periods of sobriety. where sometimes the mother just isn't there, and then other times too much there. You could imagine this kind of effect. What I did was put together those theories, and this is something I invented as a theoretical typology to try to correlate theoretical types of etiology with what might be the sort of prototypic presentation using the criteria of DSM. So what I call type 1 is this affective type, moderately heritable subaffective vulnerability precipitated by environmental stress. That would be characterized by affective instability, reactivity of mood. That's criteria number 6 in the DSM-4, and recurrent suicidal behavior. Type 2, I called impulsive. Here, people like Mary Zimmerini or Hollander, Larry Seaver, and others have written about it. Here, it would be a moderately heritable impulse spectrum disorder, characterized by impulsivity and also suicidal behavior, but of an impulsive type. Type 3 I called aggressive, based on the Kernberg concept. Again, moderately heritable aggressive temperament or a secondary reaction to trauma or abuse. Here you might have inappropriate intense anger and irritable version of affective instability. In type 4 I call dependent, which is this intolerance of aloneness that Gunderson's talked about. And here you might have frantic efforts to avoid real or imagined abandonment and anxiety-flavored affective instability. And then type 5 I call empty, really the type that would reflect the works of Mahler, Annabelle Buey, and others. I like this term, the failure to develop an evocative memory, meaning there was no stable enough early caretaker to allow an anchor of a solid identity to ever get established, and forever there to be a person that the patient with this problem could conjure up from early life as somebody stable and trustworthy. And so there was really a quicksand on which the rest of the house was built. So let's move down the last few minutes that I have to talk about treatment and where we are. I was fortunate to be a participant in the early stages of the what's called Collaborative Longitudinal Personality Disorder Study, or the CLIP study. It's NIMH funded and now in its 10th year of funding. And we looked at a number of things. This is one chart that looks at intake, patients who we were looking at who had schizotypal borderline avoidant and obsessive compulsive PD, and our control group was major depressive disorder. And at intake, we took a history of what treatment these patients had had as we started the study. And this looks at outpatient treatment. You can see that borderline is the winner, if you can call it that. The borderline patients had shown history of the most treatment, both in outpatient and also in residential treatment, even more dramatic here. And certainly, if you look at that compared to schizotypal or even major depressive disorder, it's pretty dramatic. It's a slightly different chart, but here we're looking at medications. And the main thing to point out here is that in the personality disorders here, we controlled for any comorbid axis 1 conditions. So borderline, after controlling for axis 1 depression, uses more antidepressant medications than major depressive disorder in their reported history. We also worked hard in the American Psychiatric Association to put together a practice guideline for treating patients with BPD, and I was lucky enough to be able to chair that with a terrific team, which is listed here. And these are really some of the experts who contributed wonderfully. And that was published in the American Journal of Psychiatry in 2001. Not going to go into it in great detail, except to point out that it's the only practice guideline that's an evidence-based guideline for which the core primary recommended treatment is psychotherapy, with adjunctive symptom-targeted pharmacotherapy. And one of our key participants on that was Paul Soloff, who's here in the room and who will be talking to us later. He reviewed the literature and helped us really sort through the evidence base for this pharma component of treatment. The main treatment that had already been studied with randomized controlled trials was dialectical behavior therapy, the Marsha Linehan and her group. And this just tells you a little bit about what those studies showed, which was a reduction in parasuicidal behavior a better ability to stay in treatment, a reduced number of hospital days, and improved scores on global assessment and adjustment. But we also had a very different set of studies by the Bateman and Fonagy group, which also was a very carefully done randomized controlled trial, but using a partial hospital model, and this was based on a psychoanalytically oriented individual and group therapy approach. So a very different treatment approach, but also showing pretty remarkable gains with a reduction in the self-destructive and self-injurious behavior, an improvement in functioning, and maintenance of those gains for 36 months. And as more data since these continue to look very good. The common features, to put sort of all these together of recommended treatment, number one, it's not brief. There's no quick fix. Now we're hoping that we're going to get better at that. If Martin Bovis gets here, and I hope he does, he's going to be talking about a 3-month inpatient model of DBT that's showing some very promising results in a 3-month window, as opposed to what most studies have been showing. I would quickly add that 3-month inpatient treatment is not the start to finish comprehensive treatment needed by these patients, but a 3-month block of treatment on an inpatient basis, followed by continuing treatment on an outpatient basis. These are outpatient studies which show mostly that you need at least a year of steady, continued treatment. So there's not a quick fix to come up with. We wish we could persuade the managed care organizations about this because it's far more cost-effective to pay for the treatment that works rather than to pay for a little bit and stop and revolve the door. And other characteristics you see here. I'm going to run out of time, so I'm going to move a little more quickly. No matter what kind of treatment you pick, you're going to prioritize your strategy. And you start with high-risk behaviors, then you start with move to behaviors that might lead to interrupting the treatment itself, and then move to a whole series of additional types of areas of focus. This is work from Gunderson, again, looking at practical contracting. We don't use the word in the guideline. We said instead establishing the treatment framework, because we thought contracting is a little bit misleading. It makes it sound more real than it will be. I often say that the only thing you can be sure of in a contract that you draw up with a borderline patient is that it will be broken. And that's the only thing you can be sure of. But what you have to set up is patient goals and therapist goals, work this out as a partnership, talk about it together. If you think about when things might be able to get better, Gunderson does an effort here to look at if you're just trying to make feelings better, you probably could do that in a few weeks. Maybe you could make some progress with some behavior in a few months, and then a personal style and intrapsychic change is going to take a long time. How quickly that change may occur or the nature of the work based on frequency of sessions. We're going to be talking about coping and feelings if you're not meeting terribly frequently. If you can have intensive, frequent meetings, you may have a better intensity of focus on intrapsychic areas. People sometimes ask me in New York, are you a Cohoosian or are you a Kronbergian? Meaning, whose school do you subscribe to? And I would say that's the wrong question. The question is, what kind of patient are we talking about with the diagnosis of borderline PD? And then you think about what kind of treatment approach might make sense for that patient. Because if you read the case studies of Cohut's work, most of these are patients who sound very different from the patients described in the work Kernberg talks about. And it goes back to that pathology. I think we're talking about different flavors of borderlines. Bateman and Fonagy emphasize the attachment fault in these patients. And I think that's becoming a very interesting area of focus. They're using something called the adult attachment interview and have developed a notion of mentalizing that involves what we used to call observing ego, notions of empathy. This overlaps, and they would readily say so, with both DBT and with transference-focused psychotherapy. They've developed what they call mentalization-based treatment that includes something called the capacity to sort of become the vehicle for the patient's hearing self. And this would be overlapping very extensively with an approach and a theoretical model that the Kernberg group would use. Again, you're going to hear a lot more about this later. This is just a word or two about transference-focused psychotherapy that Harold Koenigsberg here has been in the past very close to and working to, and I've worked with the Krenberg group in the past, John Parkin and others. And it really looks at a basic assumption that there is distorted links between the intrapsychic notion of our relationship with other people, heavily flavored with intense affect, and that this needs a steady, consistent interpretation. Early studies have looked promising. There's a randomized controlled trial that's virtually done at this point. We'll be looking forward to those results that shows specifically what we're going to see to compare DBT with structured supportive therapy with manualized transference-focused therapy and see how those compare. The guideline was updated in 2005, and this is on the APA website. And this is not in your syllabus, and I apologize, but I put this in because this is just 3 little slides that I'm going to try to pull together from the material that I'm submitting for next week's meeting in New York, where we're trying to conventionally reconceptualize. And really, what I suggested here was what would be a sequential theoretical model of BPD pathogenesis. So if you think insecure attachment is an early, frequent, critical feature of the histories of these patients, and it's linked to risk factors that we would call these endophenotypes of impulsive aggression and affective instability. Put this another way, if these endophenotypes were there, but you didn't have insecure attachment, but you had a good, secure home environment, these problems might not develop. But if you were dying, you then have the result of unstable interpersonal relationships, characterized by all the things we've seen. I apologize for this. I can actually make this chart available and hand it out to you later because you can't read it up here, but this is actually what I put together is a set of comparisons of DBT, mentalization-based treatment, transference-focused, schema-based therapy that Jeff Young talks about, CBT, and pharmacology, looking at core targets, treatment goals, length, what the published studies are, and reported results, and that's again for next week's conference. Now, the last thing I want to quickly say is that we're getting some interesting data about longitudinal stability. And this is studied by Zannarini. And look at this. Over 7 years, about 73% of the patients remitted, that is, no longer had the threshold diagnosis. In the CLIP study, at 4 years, if you define remission, remember all these patients at intake met 5 necessary criteria for the diagnosis. Okay. If you define remission as no more than 2 criteria for no more than 2 months, only 38% have not remitted over 4 years. Raise the bar and say no more than 2 criteria for 12 consecutive months. Only 50% still have the diagnosis for 4 years. So this is a wake-up call. We've defined these disorders as stable and persistent over time. That's not what the data show. This makes it look axis 1 like. And we think, in fact, we're going to have some radical rethinking of the way we're thinking about these disorders from data like this. The last slide I have here is a theoretical slide from Bruce Fowle, which shows a hypothetical patient showing intensity of pathology on the vertical axis and age on the horizontal axis, starting from age 15 to age 50. This patient had depression, impulsivity, and self-centeredness. So, 2 very severe depressive episodes, and others that were not as bad, and ultimately that seemed to level out. Impulsivity was a little harder to get under control. Lots of theories about what happens when we age, and that maybe there's a mellowing process that occurs. Maybe it's the involution of the locus coeruleus and other things going on biologically, combined with finally growing up and getting a little more mature, who knows. Self-centeredness, forget about it. Nothing changes. Now this is theory, but the point I want to make here is you've got to pick your battles when you're working with these patients. And if they're, as with all of our patients, things we may not like, it may be that that's going to still be there. And we're not going to necessarily change that, nor should we necessarily try. What we want to do is help with the things where we might make some progress for the patient to be able to function and feel better. So I have now set the stage. I am done, so let me stop at that point. And then I will